All right, now we're moving into the trauma stuff. First chapter, moving into trauma, is going to be chapter 29, which is bleeding and shock. Kind of some of our goals from this is to have, kind of a knowledge of the causes, pathophysiology, and management of shock, as well as the respiratory failure or respiratory arrest and cardiac failure or cardiac arrest. And then what do we do post resuscitation from management? So we want to be able to apply fundamental knowledge to provide our basic emergency care and transport to an appropriate destination based on our assessment and what we're doing for the patient. So the three main topics that we're going to discuss here are first going to be the circulatory system, which should be a review back towards the beginning of the book, but it's a critical concept to understand with shock management and just trauma in general. And then we'll talk about shock and then as well bleeding. Kind of an image here that's going to just show you the systematic flow of blood through the system of the body. And understand that there's going to be three main components we're going to talk about here: the heart, the blood vessels, and then the blood that flows through them. For it to function properly, all of these components of the system must remain intact. And as we go through the trauma and shock in general, you're going to see what happens when that becomes a not intact system, and then what you have to do to care for the problem. So the first component here is going to be the heart. It's a muscular organ. Remember, it lies within the chest, kind of left center of the sternal area. Hopefully that's something that you have a good grasp on at this point of the textbook. But it is going to be the organ that pumps the blood, supplies the oxygen and nutrients to the body's cells. To provide sufficient supply of oxygen and nutrients to all parts of the body, the heart must pump at an adequate rate and rhythm. So if you start to have any pump failures, then you're going to start seeing some systematic failures going on kind of around the body, depending on what the nature of the situation is. The trauma chapters are going to go through in depth, different things from arterial bleeds and how to worry about that major bone breaks that can cause bleeding internally, to organ damage that has severe internal bleeding. And then these all can cause shock based on a pump problem because you're losing volume and the heart's not able to get the blood where it needs to go. So from the heart, then the goal is that the arteries are going to carry that oxygenated blood away from the heart through your body. Remember that these arteries can be under a great deal of pressure when the heart contracts. We measure that pressure by taking a blood pressure and then getting your systolic and diastolic readings with that. The artery is a thick muscular wall that enables it to dilate or constrict depending on the amount of oxygen and nutrients needed by the cells or organs that it feeds. Arteries are going to be the ones that, as you go through the trauma sections, you're going to see the bright red blood if you have artery damage. Then as the arteries carry the blood to whatever the desired location is in the body, they're going to meet the capillaries, which are going to be these microscopic blood vessels. At this point, through the cells of the body, the cells will take in the oxygen and nutrients that it needs through the capillary walls, and then at the same time, it's going to push back the carbon dioxide and waste from the cells to return back through the body through the natural process. And then once that transition has taken place at the capillary level, then your veins are going to be what carries that oxygen depleted blood back to the heart and then the waste products back as well. Um, so as you look at your body, you think, how does blood pump back up without everything settling down? Well, think of your body as all of these veins have valves in it, so it pumps it up, kind of holds it in one spot, pumps it up, holds it in one spot. If you move on to the paramedic level, once you start learning about IVs, valves make a lot more sense, because when you're starting the IVs, you can actually run into those valves. Makes it a little bit more challenging to start the IVs, but basically that is how the blood is prevented from backflowing into the body. And now we kind of move into the functions of the blood. So obviously the first one, which we've discussed here a little bit, is the transportation of gases, where the blood carries the oxygen to all the critical components of the body from the heart. And then once the transition process has taken place, it carries the carbon dioxide and other waste products back to where their ending point is going to be. Second component here is going to be nutrition, of which the blood circulates nutrition really from the intestines and storage tissues, places like the fatty tissue, the liver, the muscle cells, and then it takes it to other body cells. Next topic here is excretion, where the blood carries waste products from cells to organs such as the kidneys. That's going to eliminate that waste. With the kidneys, obviously, it's going to eliminate it through urine. And then protection, blood carries antibodies and white blood cells. I can obviously attest more to that right now, a month after dealing with this cancer issue. But it's going to carry antibodies and white blood cells that's going to help fight disease and infection. It also carries platelets and clotting factors, so that if you are bleeding, it helps to control that bleeding, hopefully stop that bleeding through a natural process. And then the last thing is with regulation, where blood carries substances that controls the body functions, such as hormones, water, salt, enzymes, chemicals. It plays an important role in regulating body temperature. So the blood is really a critical component to life in general. And so you're going to learn that shock and hypoperfusion, it kind of the whole process as to why it's bad for the body and why it can be so lethal for the body. And as I just mentioned, so two key words to know are going to be perfusion and hypoperfusion. So perfusion is the goal. It's adequate circulation of blood throughout the body. Hypoperfusion is when we have an inadequate supply of blood throughout the body. And this can be caused by a whole slew of different problems. Moving forward through the next few chapters, it's going to be basically shock that we're talking about, blood loss, traumatic injuries are going to be the main concepts for the next few chapters. So now moving into shock. Shock is going to be defined as inadequate tissue perfusion, and it's going to occur when the circulatory system fails. Now there are going to be a whole number of different shock that you can talk about, from cardiogenic shock to neurogenic shock to hypovolemic shock, which is what we'll talk about mostly through the trauma sections. If hypoperfusion persists for a prolonged period of time, then that blood and everything we talked about the previous slides of trying to get all these nutrients and oxygen to the cells, if shock occurs, this isn't happening, which means any of those cells and organs will eventually die because they're not getting what they need to survive. Now, as you look at the pathophysiology of shock, there's going to be four primary causes that occur that's going to cause the shock to happen. The first one is going to be a volume problem. So this is basically going to be there's not enough blood in the system to get the nutrients, the oxygen, everything to where it needs to be. The second one's going to be a pump problem, and that's going to be basically where you have an issue with the heart and it's not pushing the blood to where it needs to go. The third one's going to be a blood vessel tone problem, and that is going to be basically where your blood pressure drops to the point that your blood vessels can't carry the blood where it needs to go. And then the fourth one is going to be an obstruction of blood flow. So something has blocked the flow of blood and it's not letting those nutrients, the oxygen-enriched blood, get to where it needs to be. So as you're trying to figure out what the problem is so that you can correct it in an ambulance, these are kind of the four things you need to think about with shock. And are these something that you can correct? So like most of these, you're probably going to need advanced level providers. So if it's a volume problem, there's nothing you can do to increase the volume, but advanced level providers can. But things like blood vessel tone problems could be caused from a severe anaphylactic reaction, and that is something that you can correct. So just understanding the nature of shock and then looking for what the cause could be so that you can figure out a course of action to correct it. So talking about hypovolemia and volume problems, the first one is where blood is lost, and that is called absolute hypovolemia, and this is an actual physical loss of blood within the system. The next one is going to be where plasma is removed from the circulatory system. So you haven't actually lost any blood, you're not going to see bleeding, but what happens is the liquid portion of the blood which is the plasma, is removed from the circulatory system. So things like severe dehydration and even burns, they shift this liquid portion away from the blood, and this is called relative hypovolemia. Either way, they cause there's not enough blood volume in the blood vessels, so the pressure falls. And the body will compensate for a while, but at a certain point, once the shock sets in, then that pressure starts to fall, and basically all the nutrients and oxygen-enriched blood can't get to where they need to go. So in both cases, both absolute and relative hypovolemia, it's called hypovolemic shock. And then you also have what's called hemorrhagic shock, which is going to be a loss of blood. So if you get to a bad trauma and their blood pressure's in the tank, they look like they're in shock, everything points to shock, and there's a huge loss of blood, that's going to be the hemorrhagic shock. Pump problems are going to be basically an issue directly related to the heart. And these are usually really, really bad because the heart is the first component that's going to try to compensate for other issues within the body. So if the heart is the problem, then you lose your first compensation mechanism. And that's why, when you read your textbook, it says that many of these result in fatalities. So it's going to be caused by a failure of the heart to pump blood, usually from a mechanical reason, such as a muscle that closes the valve, or an issue with the heart ventricle. This basically means that blood cannot be moved because of the drop in blood pressure, and this one is what's called cardiogenic shock. So Marcy covered the cardiac chapter. I'm guessing it talked about this a little bit then, but this is going to be cardiogenic shock. So talking about blood vessel tone problems, and this is going to be when all of the blood vessels dilate at the same time. So your body has a natural response that your blood vessels will contract and dilate as needed based on what's going on within your body. So if a specific portion of your body needs the blood, then these vessels are going to do what they have to do to get the blood to that body. And in return, another area that's not being affected is going to do the opposite. to keep that blood going to where it needs to be. Now, there's only going to be so much blood in your system. So if all of these vessels were to dilate at once, now you're going to have an issue where there's not enough blood for the system. And this is what is going to be called distributive shock. There's going to be a few different kinds of distributive shock, of which you will all see in your EMS career. And they are anaphylactic shock, neurogenic shock, and septic shock. So anaphylactic shock is going to be that severe allergic reaction, and it's going to cause the systematic vasodilation and massive drops in the blood pressure. The good news is this is one that you are able to fix with your EpiPen, and hopefully it works, and then that kind of puts the system back to where it needs to be. The second one's going to be neurogenic shock, which is a result of the spinal cord injuries. And basically with these spinal cord injuries, your body's not now able to send out those key messages to the nervous system, and as a result, there's going to be a systematic vasodilation, and then the blood pressure can drop rapidly. The third one being septic shock, and it's a very, very dangerous form of shock. Incorporates elements of hypovolemic and cardiogenic shock. Basically, there's an infection within the body that causes this inflammatory response. The problem with septic shock is it can also send out toxins simultaneously at the same point, which can affect your pumping ability as well. I know that a lot of EMS systems are moving to sepsis alerts based on certain criteria. It's kind of the new and upcoming thing. So as you move forward through your EMS career, you're probably going to see a lot more on septic shock and sepsis, and the treatment and kind of the whole warning system before you even get to the hospital. So this covers the whole blood vessel tone problem. And then that last topic here was obstruction of blood flow. And it's exactly as it sounds. The blood flow has been blocked. It's technically called obstructive shock, but it's not allowing the blood to get to the lungs to absorb that oxygen. It's not allowing your waste products to get to where they need to be. Three of the primary culprits for this are going to be pulmonary embolism, cardiac tamponade, and then tension pneumothorax. And basically these just block off the flow of blood from getting where it needs to be. So another important concept to understand is called fight or flight. And basically your body has natural mechanisms in it to help ward off issues. So in this situation, there's what's called baroreceptors, and they're in your aorta and carotid artery. And basically they sense this decreased pressure, and when they sense this, it stimulates the body to release epinephrine and norepinephrine into the bloodstream. When this happens, the blood vessels constrict, especially in the skin, kidneys, and the GI tracts. So the skin's going to become extremely cool and pale. At the same time, your body's going to dump, the sweat glands are going to dump all of their contents. So you're going to become extremely sweaty, diaphoretic is what we call it. And then with that, your kidneys are going to constrict the vessels as well in an effort to produce less urine to keep that volume within the body. You're going to have significant nausea and vomiting with this, and then your heart rate is going to increase to try to counteract the blood pressure dropping, to try to put more pressure in there. As somebody that had never dealt with this, I actually understand this fully now from a personal level. After the procedure that I had a couple weeks ago, I basically had this happen. I sat up, immediately became extremely nauseous. I can't even describe how nauseous I became. At the same time, I just started pouring in sweat. They laid me back. My blood pressure had tanked for whatever reason, if it was a reaction to the medicine that they had given me because I came out of surgery with high blood pressure, or if it was a reaction to the chemo treatment they had given me. But regardless, my blood pressure had dropped and my body kicked in, and all of this happened exactly as it says here. So you will definitely know when this happens with the patient, and then you need to kind of kick your thought process into overdrive, get them laid back, get their blood pressure taken, start trying to figure out what's going on. So the body is a truly remarkable organism in how it reacts to some just crazy things that can happen to it. And basically, the body compensates for so many different things that can happen to it through many different mechanisms. But basically, it's very predictable in how it does compensate. So the whole goal is to restore blood flow. This is done through the regulation of volume. It's done through vasoconstriction, and then it's done through a cardiopulmonary response. Collectively, this compensatory action is called compensated shock. Now, the thing you have to remember is that the body can only compensate for so long. This is your window to fix things. While the body's compensating, you have to be able to assess and treat and correct these issues, because once the body loses this compensatory mechanism, then it's going to be a lot harder to get the body back to where it needs to be to sustain life. Kind of one sidebar to the compensation is with pediatric infants and children, because they compensate extremely well, and you won't notice the big changes, like the big dips in blood pressure, until they've reached a point where it can be very critical. So basically, blood pressure may maintain from your readings until half of the blood volume has been depleted. And then once they start to decompensate, it goes really fast. So never wait for a drop in the blood pressure to identify shock in these pediatric patients. It's more important to rely on the heart rate. So if you have a pediatric patient that you believe could be in shock, the first thing you want to look for is elevated heart rate, because that's that first compensatory mechanism that their body is going to do. Is it going to start pumping faster and faster to keep that blood going as long as it can? But then the problem is once it fails, it goes fast. So just a little sidebar to keep that in mind when you're talking about this with pediatric patients. So once you get past the body being able to compensate, it goes into what's called decompensation. So compensated shock is going to require more fuel. As the body runs out of fuel to compensate, then it's going to become decompensated shock. So you're going to see those early warning signs, things like the diaphoresis, the nausea that we talked about earlier. That's the body kind of compensating and kicking different mechanisms in to kind of prolong things. If you don't get things fixed, then it goes into this decompensation, where you're going to start seeing a drop in the blood pressure. They're going to have mental status changes, so they might become, like in my case, I actually became unconscious at one point during one of my episodes, but they were able to quickly reverse that. And then the heart will eventually slow, and the respiratory rate will eventually slow. And again, these are your windows to try to correct the shock issues. If you don't, you're going to keep moving down these phases to the point where the next slide is going to talk about irreversible shock. So if you cannot correct the shock issue, at a certain point, it's past the point of return. Like, really, the only thing that's going to come forward with it is going to be death. So we're still, even in the decompensation phase, it's a little bit more of that pucker factor as you're treating the patient, but now's the time. Like, you got to get things fixed. And then, like I said, this is the point of no return. This is the point that you don't want to get to. Irreversible shock will lead to death. And basically, it's going to be that prolonged vasoconstriction that is going to cause significant enough damage within organs, and then over a period of time, it's going to cause death. As these organs begin to fail, you can't really reverse it. It's going to end up resulting eventually in apnea and cardiac arrest. I can tell you from personal experience that having a family member that was very severely burned, spent a couple days in Iowa City, it kind of went through all of these different phases. And then on day 2, they started talking about the organs were shutting down. And once that started to happen, we kind of knew what the imminent result was going to be. Your body can only hold on for so long. And then that was the point where the doctors came in and said, it's a matter of time. There's nothing we can do at this point. The kidneys are failing. Other organs are failing. And then ultimately what happens is they go into either respiratory arrest or straight into cardiac arrest, and then death occurs. So moving into the patient assessment, kind of specific to shock, although go back to your patient assessment chapters, go back to that NREMT patient assessment sheet that we've utilized, and it's going to be the same. The first thing that you have to try to do is identify the underlying problem and see if it's something that you can correct. If it's something that you can correct, obviously correct it. If it's something that you cannot correct, but maybe utilizing an ALS rig can correct, then make sure to get ALS coming. Otherwise, rapid transport, get them to an appropriate destination so that hopefully that problem can be taken care of. You need to recognize those stages of compensation that we talked about. Is this early on, or is this a little bit later on, to determine what your course of action is going to be? As you pull up to the scene, very beginning portion of the assessment process, do a scene survey. Look for that mechanism of injury, mechanism of illness. But does this look like something that could cause significant enough issue that my patient could be in shock from? Not to say that you don't get to something very minor, at least that looks very minor, and they could still have stuff going on that can cause shock. But use the tools that you have in front of you, survey for that mechanism, and then move into your primary assessment. That portion of the assessment that just takes a few seconds, and use all of those tools to help determine as far as ABCs, AVPU, those components are going to be critical in determining just how far basically your patient could be into shock. Again, here are some very simple concepts. It's been covered multiple times through the course of this class so far, but start with airway and then correct any airway problems immediately. Doesn't matter if they're bleeding profusely from their leg if you can't correct the airway problem. Never let your patient become or remain hypoxic. If they're not breathing adequately, then it's time to grab that BVM and start treating the hypoxia, getting them some supplemental oxygen. Moving into circulation, look at that skin color. Like we talked about, that early phase where they're going to become pale, diaphoretic. These are things that you should be able to recognize very quickly in this portion of the assessment. Assess distal pulses. Remember when we talked about blood pressures, if you reach for a radial pulse and you can't find one, that should be an indicator that the blood pressure is probably below 90. So then you just start moving your way up until you find that pulse, and then it's time to start thinking about, all right, now I need to get a valid blood pressure. Pediatrics especially, check that cap refill time. If they're in shock, usually cap refill is a great tool to utilize to see how the blood is perfusing through the body. And then heart rate being the fourth thing listed here. Again, a great tool in pediatric patients, because if it's elevated, then that could be your early indicator that there could be a shock issue. Treat any problems you find immediately. Like we've talked about a ton through the assessment. If there's a life threat, stop, treat that problem. You don't need to move forward. You stop at that portion of the assessment process and take care of it. And then you want to start trending those vital signs, because if they're in early phases of shock, you want to have that initial set of vital signs so that you can trend it through your transport and see, well, now their pressure's dropping, their pressure's dropping, their pressure's dropping. It could be a big red flag for you. But it's important to get that set of vital signs fairly early on in the process. So the physical examination, identify conditions that are associated with shock, and start by identifying some of the very common causes. So hypovolemia being a very common cause. If you are seeing things through your physical examination that might indicate hypovolemia, then start looking for certain situations that may cause it. Is the patient bleeding? Are they dehydrated? Is there something that would be causing this hypovolemic shock, especially in children? Patients with allergies, are they having an anaphylactic reaction for whatever reason? So just use your assessment tools to try to figure out, start with the common things and then work backwards from there. Then move into your secondary assessment. So you're identifying the mechanism of injury. You're identifying what the history of the present illness is. You're identifying what the actual chief complaint is. And this can change throughout the process of shock because, like we've talked about, as you go through these different phases, so many different things are going to happen to the body that you may see many of these changes throughout the time that you spend with your patient. Continuing through this patient assessment, identify and control massive hemorrhage within the first seconds of a primary assessment. So massive hemorrhage is one of those life-threatening conditions that when you see it, stop, fix it. We'll talk about different techniques later in this chapter that kind of go through different ways of controlling that massive hemorrhage, from tourniquets to clotting agents to just all the other things that you can utilize. But if you see this massive hemorrhage, stop it as soon as possible. Then ensure that the airway is open. If it's not, open it. Ensure that there's adequate breathing. If it's not, then grab your BVM and assist them with ventilations. If you need to put an airway adjunct in to make sure that you're ventilating properly, now would be the time that you're putting that airway adjunct in. But also understanding that depending on the situation and the trauma, nasal airway may not be indicated. An oral airway would be the better route, but if they still have a gag reflex, then you can't use the oral airway. So all of these are assessment tools that you have to use. As for the non-massive bleeding, you really only need to worry about that after you get done assessing and treating the prior elements that we've talked about. And this is going to kind of be a judgment call on your assessment and what your knowledge is. When in doubt, err on the side of caution, treat it as a massive bleed. But if it's something that's obviously not a life-threatening condition, then you continue through those key assessment components and then come back to that. Just be aware of signs and symptoms of shock and don't wait for them to appear. Like we talked about with the compensation mechanisms within the body, if you wait too long, it might be too late. So you have to be on your toes with your assessment process when it comes to shock and understand all of those signs and symptoms and be aware so that you can treat them as you see them. Understand the different mechanisms of blunt trauma that may cause the internal bleeding. Was this a ground level fall, or did they fall from a porch roof? It's obviously going to probably take you two completely different directions based on what that mechanism is. If it's a motor vehicle or motorcycle accident, what kind of accident was it? Was it a head-on? Was it a rollover? Was it a single vehicle? Was it multiple vehicles? Were they wearing their seatbelt? There's so many different indicators that go into your thought process that you have to consider, and this should all come naturally and quickly to you. And then moving down, auto versus pedestrian collisions, blast injuries, just every different type of blunt trauma that you can think of that could cause the internal bleeding, and then understanding what you have to look for is the key component of this piece of the patient assessment. Looking at penetrating trauma, was it a gunshot wound? Was it a stab wound? Is there something that's still impaled in there? If it's impaled in there, you don't want to remove it unless you absolutely have to, because it could be pinching off bleeding from occurring. So if you remove it, you may have created a bigger problem. But also understand where the wound is located. Is it in the torso? Is it in the abdomen? Is it someplace where there could be a major vessel that from going through the anatomy portion of the class that should indicate a higher need to be suspicious of potential internal bleeding. So again, just all assessment tools that you have to utilize. And then as you look at these signs of internal bleeding, you're looking at injuries to the surface of the body. What is the depth of the injury? If you're able to tell, is there bruising, swelling, tenderness over vital organs? That would be a very key indicator. Is there pain, swelling, or deformity to extremities? You can lose a lot of blood through your long bones, through your femur, through your pelvis. Something as simple as a fracture can cause significant enough bleeding that can result to shock. And then another indicator is, do you see any bleeding coming from their mouth, rectum, or vagina? If that's the case, that can also be an indicator of internal bleeding. If you see bleeding from their mouth, take a look in there, see if there's any trauma within the mouth. If it's not directly in the mouth, then it's coming from deeper in the body. Again, should be a big red flag for you that there could be internal bleeding. And then you just work your way through the assessment treatment process, always on your toes for signs of shock. And then a few more signs of internal bleeding would be when you assess the abdomen. Is it tender? Are they guarding it? Do they have rebound tenderness? Is it rigid, meaning firm? Is it distended? These would be big indicators that maybe there's something bleeding inside the abdomen. But then you want to use your baseline assessment, and then through your reassessment, see if there's any changes. If they're just slightly rigid and mildly, or maybe not distended at all, and then 15 minutes later, all of a sudden their belly's huge, they're having enormous pain when you palpate, that again is a big indicator that, hey, something's going on in there. We need to get them to the hospital to get this taken care of. If they're vomiting, what does it look like? Is it coffee ground looking like a dark substance, or is it bright red vomit? Bright red means that it's fresh blood, that it hasn't gone through any of the process of going through the body's systems. Is there dark tarry stools or bright red blood in the stool? That would indicate where the bleed is located at in the GI system. And again, it's kind of just reiterating over and over again, monitor the patient for those signs and symptoms of shock. And then just kind of take a look at the photo and think about it a second. I mean, you've all had bruises in your life. You understand that that's the blood pooling towards the surface of the body. And this is on the shoulder, so could it raise some red flags? Yeah, it could. But now take this bruise and put it over the abdomen, and what is your thought process? Location, assessment, all kind of helps you determine a course of action for the patient. So just something to look at and think about. And here's just a little image of, kind of showing you the basic signs of shock. So the first thing, like we talked about, is your scene size up. So when you walk up, you look at that picture in the middle, just take a second, think about what you see here. Obviously, the patient looks to be in bad shape. Did he fall and maybe hit his head on that piping? Is it hot outside? Could it be a dehydration issue? These are things that you have to figure out through your assessment process. So, like it shows here in the image, first thing, check that pulse. See what that pulse is. The first thing that's going to happen is that pulse is going to increase to maintain the cardiac output. Then you're going to start seeing those early signs where the blood vessels constrict, the skin's going to become pale, clammy, and eventually diaphoretic, and then the respiratory rate's going to increase because your body's saying, hey, I'm not getting enough oxygen to these places, so your body's instinct then is to say, I need to produce more oxygen, I need to get more oxygen out. And then the blood would be shunted away from the GI organs, causing the nausea there in the lower picture. Once you start seeing the blood pressure changes, you've kind of gone through all these initial phases, and it's time to start thinking, okay, it's getting worse, and we need to move forward from there and treat the patient. So now that we've talked about kind of the shock process up to this point, let's talk a little bit about treating shock. And how do you treat shock? It really depends. It depends on what that underlying cause is. And it's important to understand that sometimes it's not a problem that you can treat. The definitive treatment is short scene time, rapid transport, get them to where they need to be. If it's a volume issue with internal bleeding, that means that they need an OR. So you need to get them to the hospital where they can have surgery, stop that internal bleeding. If it's an infection issue, that's not something that you can take care of in the ambulance. They need antibiotics. So it's short scene time, rapid transport, get them to the hospital where they can identify those scenarios and take care of them. The best way to stop hypoperfusion is to stop whatever is causing it. Now, that may mean it is something that you can take care of, like in the instance of anaphylactic shock. EpiPen. Know what you can do depending on the situation. But what it all boils down to is your primary assessment and your patient assessment and the ability to perform those tasks to identify those urgent interventions and then identify other treatments that you need. The other important piece of this is gathering those vital signs, trending those vital signs, relaying those vital signs to the hospital so that they have a clearer picture of what's going on as well. So when you're treating shock, something else that you need to consider, it's called the deadly triad of trauma. Sounds terrible, doesn't it? But these three conditions, they significantly contribute to death in these shock patients. And it's acidosis, hypothermia, and coagulopathy. So basically in shock, inadequate perfusion translates to inadequate removal of waste products. In addition, diminished oxygen delivery also causes the cells to shift to different forms of metabolism and maintain cell function. So both of these things together lead up to acid buildup, which decreases the body's pH. Acidosis, which is low pH, it's particularly dangerous in hemorrhagic shock patients because it changes the body's whole ability to clot. And if you can't clot, then the body's natural mechanism for stopping the bleeding has gone away. So that's what this clotting deficiency is called. And then with that, cellular metabolism is an important element in the heat production for the body. So when the cells slow and stop due to hypoperfusion, you could be in a hot environment and the body temperature can still plummet rapidly because it's your body's reaction to everything that's going on. Basically, when the patient's cold, they're going to bleed more. In severe trauma, these clotting disorders can also occur naturally. Typically, the larger the problem, the more often coagulation becomes a problem. So consider that shock in many patients is caused by bleeding. Conditions that lead to the inability to clot becomes extremely dangerous. You won't necessarily know that you're seeing this in the field, but at some point during your career you probably will. It's a patient called DIC where the body loses the ability to clot. So in essence, it's important to understand, treat the specific root cause if you can, and try to get the patient to the hospital as quickly as possible. Anytime that you see shock, it should be the premise that I need to load and go. This is a critical situation. I need to get the patient to the hospital to get this taken care of. So keep those in mind. Acid base, understanding pH. After 20 years, it's something I still struggle with, but it does have a big effect on the body's systems. So now, treating what we just talked about. Like I said, the first and most important, short scene time, initiate transport, go to an appropriate destination. So knowing the facilities that you transport to and what capabilities they have are important in these situations, because if you're taking a patient that is in hypovolemic shock to a hospital that doesn't have perhaps an OR on-call team, it doesn't do them any good. You want to get them to a facility that can take care of the problem. Prevent hypoxia. Managing the airway and preventing hypoxia reduces that risk of acidosis, and that is associated with the clotting issues. So to best treat these shock patients, be aggressive with your airway management. If there's any evidence of hypoxia, then get them supplemental oxygen and be prepared to assist with their ventilations. Prevent heat loss, because it's also linked directly to the clotting issues. So temperature regulation is really important. Remove wet, bloody clothing. Make sure that you keep the patient covered, warm from head to toe. If you have to, consider external heat sources such as warm blankets, which you're probably not going to have in the ambulance, but you might be able to use some heat packs to help kind of warm the outside of the blankets up to help keep that heat loss to a minimum. Consider shock positioning. So depending on what's going on, utilize gravity to your advantage. You may have to elevate the feet, lay the patient down flat. Just make sure that you're positioning them based on your assessment. And then as always, consider that need for ALS. They're just going to be capable of a lot more than you at the basic level. So when you get in these situations where you're thinking shock could be the issue, it's probably time to start thinking, hey, let's get somebody else coming. You can always call them off if something changes, but it never hurts to have them coming to help treat the patient with what they can do versus what you can do. Now we're going to move into the bleeding portion of the chapter. And so the first thing to understand is that hemorrhage is severe bleeding. So a major cause of shock is hypoperfusion and trauma. So severe bleeding means you're going to lose that volume, which in turn is going to start causing the issues of shock. So the two types of bleeding that you need to know about are internal and external, and they're exactly as they sound. So external bleeding is what you're going to see. It's any wound on the outside of which blood will be visible. Internal bleeding is going to be the bleeding that you can't see. So there's some sort of damage inside the body that hasn't penetrated the skin of the body, and it's bleeding inside into just the spaces within the body itself. This is where you'll start seeing bruising and things like that eventually. Significant abdominal bleeding, you'll see all those abdominal signs of distension, pain, things like that. So just very basic types of bleeding there. Now when you can see the blood, there's going to be basically three different types of injuries. The first one, and usually the most dangerous one from an EMS standpoint, is going to be arterial bleeds. This is going to be the bright red blood. It's usually going to be pulsating, spurting with the pulse. So every time you feel a pulse, it's going to shoot a little bit of blood. It's going to shoot a little bit of blood. But it's going to be bright red. It will generally bleed out a little bit faster because it's under pressure. So it's going to push more volume out in a shorter amount of time. The next one is going to be venous injuries, and this is going to be that darker red color, usually a little bit easier to control the bleeding with direct pressure, and it's usually a slow and steady flow. And then kind of superficial injuries are going to be capillary blood, and it's just a slow, even flow. I would describe it more as like an oozing of blood at the surface there. So the three different types of blood that you'll see coming from those external injuries. So again, just to kind of reiterate, that external bleeding, it's going to be on the outside of the body. Something has penetrated the skin, lacerated it, and destroyed the underlying blood vessels, which then lets the blood basically leak out through wherever the hole is in the body. It's going to typically be visible on the surface of the skin. Now, how much a person bleeds? Well, that just depends on the size and severity of the wound. Obviously, the larger the wound, the more blood you should expect. The size and the pressure of the vessel that's been damaged. So if you damage a vessel in your finger, it's probably going to be smaller. You're probably not going to see a tremendous amount of blood versus if you hit a vessel in your upper leg or upper arm, those are usually going to be larger vessels. It's going to push more blood out. And then the other thing is going to be the individual's ability to clot. So the body is going to try to clot itself off, but if they're on blood thinners, for example, you should expect to see more blood because their blood's going to be thinner. They're going to have a harder time clotting it off versus somebody that's not on blood thinners. So with the arterial bleeding, like we said, it's going to be that bright red in color. It's usually going to spurt with the beat of the heart, and this is the oxygen-rich blood. The thing to remember with arterial bleeding is if it's a massive arterial bleed, all of that oxygen-rich blood had a destination, and now it's not getting to its destination, which means some places being deprived of oxygen depending on the severity of the injury. If it's severe enough, this is where you'll start moving through the process of shock. So something to keep in mind with that arterial bleeding is just that oxygen needs to be delivered someplace, and if they're bleeding it all out, it's not being delivered. So life-threatening, yes. Something that you have to address immediately, yes. Now the venous bleeding, like we talked about, is going to be the darker in color than the arterial bleeding. So it's going to be kind of a dark maroonish red. It's going to be under less pressure than the arterial bleeding, so you shouldn't see the spurting, but you can see a large blood loss depending on the vessel that's been damaged. Now, when we talked about the arterial bleeding and you have to be concerned about that oxygen-rich blood getting someplace, this is a little bit different mindset because with venous bleeding, the biggest thing you're concerned about now is a volume issue. If you lose enough blood and you lose that volume within the body, now you're talking about shock due to volume loss or hypovolemia. So it can create an immediate life-threatening hemorrhage depending on how much blood they've lost. So you need to do your due diligence with assessing the patient, with trying to control that bleeding, with getting those baseline vital signs so that you can trend them. Junctional hemorrhage is going to be a hemorrhage that occurs where an appendage of the body connects to the trunk. So basically, if you take your torso, any piece of your body that comes off of that, so each of your legs, each of your arms, and your neck are what you're looking at here. The problem with these areas are these are going to be fairly large arteries and veins, and they're not well protected. So think about when you check somebody's carotid artery for a pulse. I mean, it's fairly close to the surface, right? So it's not a well-protected area, so it doesn't take a huge amount of trauma to damage one of these vessels. So in your neck, it would be your carotid artery, and then your jugular veins. If you get into the arms, you're looking at those brachial artery. It becomes pretty superficial when it gets up into the armpit area. And then your legs are your femoral arteries and the veins flowing down through there, and those are actually going to be fairly large arteries and veins. So if there is damage to one of those, it's likely going to cause massive bleeding. It's going to be difficult to treat because you can't use some of the methods that you would otherwise use, like a tourniquet. It's got to be like a direct pressure. These can be very lethal to patients. So short scene times, load and go, get them where they need to be. Try to control the bleeding as best as you possibly can, and do everything on the fly with these type of injuries. Capillary bleeding, not a huge life threat from an EMS standpoint. It's going to be caused by these superficial wounds to the surface of the skin tears on older people, things like that. They're going to be slow and oozing. Many times they'll stop without you really having to do anything, or just a simple dressing. But in any regards, always treat the patient, always dress it. Really the biggest concern that you're going to have with these capillary type of bleeding is the risk for infection. It's usually a larger surface area that occurs with this type of injury, and if an infection gets in there, then you have to be worried about how far does that progress, and it could progress all the way to the point of sepsis theoretically. So always treat your patient, always take care of it, always recommend them going to getting checked out, but this isn't something that you should see as a lethal injury while you have the patient in your care. It would be more of a down the road if it were to turn bad for them. Another consideration to have when you're looking at external hemorrhage is that it can be accelerated by underlying conditions, and most notably prescription medications designed to limit the body's natural ability to form blood clots. So when you see a patient that has any sort of bleeding, one of the first questions that you want to get an answer to is, are you on any sort of blood thinner? Because that's going to affect their ability to clot that off on their own, and it can alter somewhat your path of action depending on how bad the bleeding is. Another thing to consider is that hypothermia affects the body's ability to clot. So if the patient is hypothermic, basically it becomes more challenging for them to clot off the blood, and they lose that ability to clot. Now, the thing to think about with that too is we already talked about with earlier in the chapter that the shock can cause the body to become hypothermic on its own. So now it could create a vicious cycle if they become shocky. and hypothermic, that it becomes a little bit more difficult to treat this patient. Generally speaking, though, external hemorrhages are usually controlled fairly easily by compressing the tissue around the wound. So direct pressure is going to control the vast majority of external hemorrhages that you're going to see. We'll talk a little bit more about some other tactics a little bit further in the chapter here, but generally speaking, that's a good rule of thumb. And then back to some basics here with precautions. So gloves, obviously, always. But these are the type of situations where you need to think about masks, some sort of eyewear or a mask with the eye shield built in, and then even a gown. You don't know what that patient may have, so precaution is the best protection that you have from getting anything that they may be able to give you. And then once you're done, always make sure you properly remove your gloves and wash your hands immediately after each of these calls, and then make sure that you disinfect the patient care area extremely well as well. All right, let's move into the patient care aspect of the chapter a little bit here. For whatever reason, I noticed that some of these slides were out of order, so I threw them back where I thought they belonged, but we're going to talk about patient care right now. So first thing is initiate rapid transport to an appropriate destination. Look for shock, manage those specific underlying causes of shock. If it's something you can treat, make sure you treat it. If it's something you can't treat, either call ALS or get them to a facility that can treat it. Manage that airway and breathing to prevent hypoxia. It's extremely important in preventing shock to prevent hypoxia. Take steps to prevent heat loss. We've talked a couple different times throughout this chapter so far about hypothermia and the effects it can have on the body's ability to clot, and then the steps that it uses within the shock process as well. Place the patient in a supine position, especially if they are showing signs and symptoms of shock, so that you can keep that blood going to the central core where it needs to be, and then use your judgment, but when in doubt, request ALS. As you look for ways to control this external bleeding, first and foremost, direct pressure. Like I said, the majority of the time, direct pressure is going to take care of the bleeding issue. From there, you can move into some of these other more drastic approaches. So depending on where the injury is at, it's going to dictate a little bit on what you're going to utilize here. But the first one is going to be hemostatic agents with wound packing. So one mindset is, depending on where the wound is, you take sterile gauze and you pack the wound tight so that it hopefully helps to clot the blood off. There's also what's called hemostatic agents, which can be used kind of in conjunction with the packing, and basically these are going to be some sort of commercial product that hopefully will speed the process up. So things like combat gauze is one hemostatic agent, and it has a material within the gauze. Sometimes they'll get a little bit warm, but it helps to clot the blood off. There's products called Quick Clot out there as well. You probably think about those with like military type situations where they're dumping that into gunshot wounds to try to clot things off. From there, if you have an extremity injury that has severe bleeding that you can't control with direct pressure, then you may have to use tourniquet. And I have used a tourniquet one time in my career. They're not new, but they're fairly new from a commercial standpoint of being easily to use in the field with the combat tourniquets that we now carry. And basically the important thing here is to know your equipment, understand how it works, understand how to use it. Make sure you do the little things like you put the date and time, because that is important for down the road, because when you're putting a tourniquet on, you're cutting off that blood supply. So they kind of go on a clock once you do that, to make sure that all of that tissue doesn't die off. And then when we talked about that junctional bleeding and that it can be very difficult to control, there are specialized compression devices out there. I don't think they're commonly carried in the EMS world. I know our service doesn't carry anything specialized for junctional bleeding, but there are some specialized compression devices out there where you can put it around there, and it usually uses pressure, like almost like a blood pressure cuff, where you pump it up, and that direct pressure from that will hopefully help to pinch off and control the bleeding. So there is kind of an order of doing things. You don't just necessarily want to go straight to a tourniquet. You want to start at the beginning and then work your way through the process. So start with that direct pressure. If you can't control it with direct pressure, then you need to start considering that hemostatic agent to help augment the direct pressure and to help let it do some of the work in the clotting process. If you still can't get anywhere with that, then you're going to consider the need to start packing that wound full of packing to help try to control it and basically pinch everything off from the inside. From there, you might have to start thinking about either that junctional tourniquet or a regular tourniquet, depending on where the injury is. Regardless, you're going to initiate rapid transport. You're going to consider that need for ALS, depending on where you're at and what resources you can get to you. Time is essential in these type of situations. Be cognizant of shock. Get that baseline set of vitals and make sure that you're monitoring them frequently throughout the call, so that you can kind of stay ahead of any issues that may arise. And then finally, with patient care here, very simple and basic, but always maintain those ABCs. Consider the need for high concentration oxygen. We talked about the importance of oxygenation through this whole process of bleeding control and shock. Control that external bleeding. Depending on where the injury is, apply a splint. So a splint's going to hold things in place and prevent kind of re-aggravation of the injury as you're transporting, and it should actually help a little bit in the bleeding control if you can get a splint on it. Make sure you preserve that body temperature. Again, we talked about the whole clotting issue with hypothermia, and then we also talked about hypothermia and shock. So make sure that you're preserving that body temperature. Try to keep them warm. And then most importantly, provide that prompt rapid transport to the appropriate medical facility. Like we talked about, sometimes it's not the closest facility, it's the most appropriate facility. So make sure you're taking them someplace that can take care of the problem at hand. All right, so we've mentioned briefly a few of these strategies for controlling external bleeding. Now we'll talk a little bit more in depth about them. So first thing here with controlling that external bleeding is to, controlling the bleeding is essential to preventing shock, and that's the whole goal. Don't let your patient go into shock, because we've gone through all of the steps of shock, and that is where you can lead to a bad patient outcome. So if you don't control the bleeding and you move through those steps of shock, it can and will lead to the patient's death. So make sure that you do your part in controlling everything that you possibly can. Short scene times, rapid transport, and get them to where they need to be. Prior to any of that, first and foremost, going back to the very beginning of the textbook, you are number one. So standard precautions are mandatory. Make sure to protect yourself, gloves, mask, gown. If that means you have to take a few seconds when you get there and patient care is delayed by 30 seconds or a minute, you need to make sure to take care of yourself first. And then when the call is over, observe those standard precautions in infection control and make sure that you properly and thoroughly disinfect and clean everything after the call is over, so that you're back in working order. All right. First and foremost, the most common one you're going to utilize is that direct pressure. And this is where you are going to apply firm pressure with the palm of your hand or fingers, depending on the size of the wound, directly to where the injury is located. You want to keep that firm. I mean, when I say firm, like you're putting a lot of pressure on it until that bleeding is controlled. Resist the temptations to continuously look. Oh, did it stop bleeding? Oh, did it stop bleeding? The other thing that you need to resist is the temptation to just add more absorbent layers, because if the first layer soaks through and you just put another one on top of it and it soaks through, you're not doing anything to stop the bleeding. You're just catching the blood on the way out. You don't want to remove layers either. So you want to have that first layer of absorbent dressing on there. Put your direct pressure on there. You're not going to do anything unless that layer completely saturates through, and then you want to slip another layer on between your hand and that layer and continue with the direct pressure. But generally speaking, you have to be a little bit cautious and resist these temptations that you may have. Once you have the bleeding controlled, then you want to bandage a dressing firmly in place with a pressure dressing. So you're going to take some of the cling wrap, you're going to wrap it really snug around, not to the point of tourniquet, but enough that it's going to maintain basically the same amount of pressure that you would have been using with your hand to control the bleeding. Once it's dressed, don't remove it. You know, don't go back in there and be looking like, hey, is it bleeding again? Is it bleeding again? Because what you can do is, as that bleeding gets controlled, that blood is going to clot off, and as it clots off and you pull that dressing back, you may pull that clot back with it. And if you pull the clot back, then you're right back to step one, which is kind of what you're trying to avoid with this whole situation. So once you get it dressed, leave it in place. Don't go snooping in there. Next step that we'd be looking at is the wound packing. So especially in those junctional areas of the body that we talked about, there's natural cavities within those areas that there's just no way around it. They're going to promote profuse bleeding. If direct pressure doesn't do the trick, then you want to augment it by wound packing. So you're going to fill those voided space within the wound with either sterile gauze, or if you have it, hemostatic gauze to help control the bleeding. Basically, you're just packing all the voids so that the blood can't pool, and then as you apply direct pressure, it hopefully pinches off the areas that are bleeding. And then with the wound packing, we'll talk a little bit about pressure dressing here. So you want to apply several gauze pads on the wounds, or an ABD dressing, which when we get you in person, we'll show you what all of this stuff looks like. But basically, you want to put that dressing over the wound, hold that dressing in place then with some sort of self-adhering bandage that you can wrap tightly enough over the wound to control the bleeding. So we'll use cling, and then you can tape it. They also have that Coban, which is the, like if you go get your blood drawn, Coban is that pliable stuff that they wrap around with a little 4x4 underneath of it to keep you from bleeding. Same concept, but you want to create enough pressure to control the bleeding, but to not be a tourniquet, basically. So that's what a pressure dressing is. And then these hemostatic agents that we've talked about a couple times, they're designed to enhance direct pressure's ability to control bleeding. So there's a chemical compound in there that reacts with the blood in the body that's going to help control the bleeding theoretically. It usually comes in the form of an impregnated gauze or some sort of dressing. And these are best suited for wound packing when you can get them in there where the injury has occurred, and hopefully it'll help clot off the blood from the inside. And then just a quick image on kind of what one of these hemostatic agents would look like. So this is the Quick Clot Combat Gauze. So it looks like just gauze, but there's a quick clot agent in there. And you can Google Quick Clot. You'll probably find all kinds of results on what it is and kind of exactly how it works. But basically this agent then helps to clot the blood off once it comes in direct contact with it. And then we move on from there to the tourniquet, which means you're closing off all blood flow to and from the extremities. So if you put a tourniquet on their leg just above their knee, everything from the knee down is no longer getting blood supplied to it, and it's no longer returning blood to the body. Like, you've completely pinched off the blood flow. When you put these tourniquets on, you're going to think it's on there tight, and you need to go and keep cranking it down until you really can't crank it anymore. And there's a couple pictures that are going to show these commercial tourniquets so you can get a little better idea of what that looks like. But it has to be extraordinarily tight to completely pinch off the blood flow. You don't want to just go straight to these things. If you can't control the bleeding with direct pressure and it's an extremity injury, then you should start thinking about going to the tourniquet. Always apply it between the wound and the heart. So you want to be proximal from the injury, basically, is the way to look at it. So if it's an injury on the lower arm, you need to be above the injury, closer to the shoulder. If it's on the legs, you need to be above the injury, closer to the pelvis area to control it. So like I said, a couple of these pictures will give you a little bit of a visual, and then we do have a couple tourniquets when we get you in person that you'll be able to go through and kind of play with and see how they work. So this is the Mechanical Advantage tourniquet, which I've never actually seen, but it looks like it's pretty simple to use. It basically looks like it must come where you slide it over the injury, kind of underneath the patient's arm. You see that yellow tab. You'll cinch that down so that the device comes tight to the skin, and then what you see him doing is turning kind of that key on top of the device, and that's a ratchet system. So every time you click it, it's going to tighten that band down tighter and tighter and tighter and tighter. And you want to keep tightening it down until you see the bleeding has stopped. And it may be a lot more than what you think. It usually, from what I've seen with tourniquets, it's a very painful application if they're still conscious. But if it's the only way you can control the bleeding, then it's the only way you can control the bleeding. Regardless of your tourniquet, just know your equipment, understand how it works, make sure that you have practiced with it so that you know how to utilize it, because when you get in the situation where you actually have to utilize it, it's going to be easy to become flustered, and it's going to be easy to make mistakes. So make sure you understand, make sure you follow those manufacturer's instructions. Once you apply it, don't remove it, don't loosen it. The patient may complain about the pain, about not being able to feel anything, but it's on there for a reason, so you need to leave it there. And then the other thing is you need to have some sort of notation so that as this patient moves through their treatment process until that tourniquet comes off, they know exactly when it went on. It's going to be a big deal for the surgeon to understand exactly when that tourniquet went on, because it's going to help him determine how long has blood flow not gone to the area, and as much as you hate to say it, it'll help them determine if it's something that's viable that they can save, or if it's something that potentially they have to amputate. And that's just part of the job that we do. But when you utilize tourniquets, knowing exactly when it went on is important. Last thing here quickly is these junctional tourniquets. Like I said, I've never actually seen them other than a couple pictures in the textbook here, but these are specifically designed for those very difficult to control bleeding areas um, around your armpits, shoulder area, and down in the groin area. Obviously, the other junctional area would be your neck, but it wouldn't be a good idea to put a tourniquet on anybody's neck ever. So these are specifically designed for the shoulder armpit area and the groin pelvis area. If your department, wherever you land, ends up having them, again, it just falls back to knowing the equipment you have, understanding the manufacturer's instructions, and when to apply it, follow your protocols. A couple other methods here of controlling the bleeding. The first one being elevation. Obviously, by elevating a area that's bleeding, you're using gravity to your advantage. And if you use that while applying direct pressure, it can speed up the process a little bit. But you do have to use some common sense when using elevation. You obviously don't want to be grabbing their arm and flopping their arm up in the air if they have a musculoskeletal injury. So if you're worried that there could be something broken, then you're not going to utilize the elevation technique. If there's something impaled in the extremity, again, don't utilize it. And then the last thing would be if you suspect any sort of spinal cord injury or spine injury, then bypass the elevation. It's not like this is going to make or break stopping the bleed. It's just one little tool that you can utilize to perhaps help a little bit. We talked earlier about splinting and how that can assist, so that falls into this other methods of controlling bleeding. But basically you want to stabilize the sharp ends of broken bones so that they don't either protrude to new areas or re-aggravate current areas that maybe you've already got the bleeding under control. Air splints are a good tool, but really any type of splinting that you can utilize to keep those bones and the extremities in place and minimize the amount of movement that they have is going to assist with bleeding control. Another method is cold application because it's going to minimize the swelling, it's going to constrict the blood vessels, and it's going to reduce the pain. You're going to use this in conjunction with other manual techniques. The thing with this is you have to remember if your patient is severe enough that you're worried about shock and things like that, this kind of contradicts a little bit what we talked about making sure to keep the patient warm. So you do have to use a little bit of common sense when you're using a cold application. If it's very routine minor call, then absolutely throw an ice pack on it. It may help a little bit with the bleeding control. If it's more of a systematic issue where you're concerned about shock more than anything, then your goal is going to be to keep the patient warm. A couple special situations here involving bleeding. First one being head injuries. So you have to be careful with head injuries and bleeding because you don't want to trap more bleeding within the intracranial area than is already there, because it's just going to increase the pressure. It's going to do more damage. So if there is drainage from the ears or nose, generally speaking, you kind of want to let that flow freely. Use a gauze pad to collect it. There is a method called the halo method where you can collect some of that blood, and if there's like a halo effect around it, then you might see some cerebral spinal fluid, and that would be a big indicator of the warning signs that you'd have to have with intracranial pressure. But again, this is specific only to head injuries. If there's bleeding anyplace else, you're going to have to control it, especially if it's a life threat type of bleed. But head injuries, they do fall into that little bit of a special situation that you have to be cognizant of. All right, nosebleeds, epistaxis. And these can be kind of annoying if you are a medical person, because what's the first thing you hear people say? Pinch your head, tip your head back, pinch your nose, tip your head back, which is completely not what you want them to do. You want to have them sit and actually lean forward, apply direct pressure to the fleshy portions of the nostrils. So pinch their nose fairly tight, keep them calm, keep them quiet. Just talking, moving around is going to prevent the clotting from occurring. Don't let them lean back. If you do, all that blood's just going into the back of their throat, and then you're going to have to start worrying about it clotting off back there, causing them to be nauseous, causing them to start vomiting, which you don't want to do, because that's where the blood's going to go if you have them lean back. If for whatever reason your patient does become unconscious, place them in the recovery position, not supine, and be prepared to suction. Because if they become unconscious, now your biggest concern is going to be airway compromise, because you're going to have a natural issue in blood becoming a potential blockage of the airway. So be prepared to suction. Nosebleeds are actually a fairly common call in the world of VMS, so it's something that you will see quite frequently. And then last thing here, just talking quickly about internal bleeding. Just understand that damage to the internal organs and the large blood vessels. I mean, think about the descending aorta and how large of a vessel that is. You know, if you damage that, you're going to lose a large quantity of blood in a short time, and it can and will result in death in a lot of patients. So you're not going to commonly see this blood loss. You're going to want to use your assessment strategies and look for signs of blood loss through bruising, distension, rigidity, things like that that can kind of be some of those telltale signs that there could be some internal bleeding. Severe blood loss, it can result even from injuries to the extremities. There's large vessels that run down through the upper portions of your legs, like we talked about earlier, your femur, your pelvis. Those bones, if you fracture them, you can lose a lot of blood in short order. So those are very significant injuries that you have to be aware of as well. But you know, it all falls back to your assessment skills, short scene times, load and go, rapid transport, get them to where they need to be, utilize ALS as you need, and then take care of the patient in the conditions that you can see. So we've reached the chapter review. You can scroll through the rest of the slides here and just kind of read them, but it's just going to be a review of what we've talked about. Make sure to read your chapter. Don't just go off what the lecture is, because there's a lot of information in that chapter that's very key. If you have any questions, let us know, and then we'll keep plugging through into the trauma sections next.